in the 7th Annual Bernard A. Sorhaindo Memorial Lecture. And the topic is Obesity, a Caribbean Dilemma. We will hear from, I was about to say my friend, well, a colleague, as a matter of fact. We both having studied biochemistry, but he has gone on much further, and very well-respected Professor Dalip.
We are delighted to have you here to participate in the 7th Annual Bernard A. Sorhaindo Memorial Lecture, hosted by the University of the West Indies Open Campus Dominica, in collaboration with the Dominica Medical Association and Optical Services Limited. Dr. Bernard Sorhaindo was the first Dominican graduate of the University of the West Indies when it started off as a college of the University of London in Jamaica. This fact, in addition to his dedicated and exemplary medical services in Dominica, earned him the honor of having this lecture in his memory. Chronic, non-communicable diseases are the leading causes of morbidity and mortality in Dominica and the rest of the Caribbean. Obesity is a common contributor. One just has to look at the televised live coverage of Carnival to appreciate the magnitude of this problem, especially among our women. The topic, Obesity, a Caribbean Dilemma, will be presented by Professor Dalip Ragoobirsingh, who will seek to examine the definition, diagnosis, and complications of obesity, and provide guidelines of how preventing and treating the disorders associated with it. Professor Ragoobirsingh is a professor of medical biochemistry and diabetology. He is a director of the Diabetes Education Program in the Faculty of Medical Sciences, University of the West Indies, Mona Campus, Kingston, Jamaica. He is also a consultant in the Diabetes Outpatient Clinic, University of the West Indies Hospital. Professor is also a graduate of the University of the West Indies. To you, sir, a warm and special Dominican welcome is extended. To this wonderful audience, on behalf of the University of the West Indies Open Campus Dominica, the Dominica Medical Association, and Optical Services, welcome. Thank you.
I have been asked to present the presenter. That is, he's very humble, and he has pleaded with me not to read everything that's in your program. Well, Dalip is the professor of medical biochemistry and diabetology and director, Diabetes Education Program in the Faculty of Medical Sciences, University of the West Indies, Mona Campus, Kingston, Jamaica. He is also a consultant in diabetes outpatient clinic, University Hospital of the West Indies. Professor Ragoobirsingh is a graduate of the University of the West Indies, so he's within the family. He was later a Rhodes Research Scholar at the Human Diabetes and Metabolism Research Center, Department of Medicine, University of Newcastle upon Tyne in the UK. He was also a visiting fellow at the Mayo Medical School, Minnesota, USA, and visiting professor at the University of Pittsburgh and Miami School of Medicine, USA. He was most recently a Fulbright Scholar to the Non-Communicable Diseases Unit of the Pan American Health Organization, headquarters, Washington, USA, where he developed a diabetes education curriculum for Caribbean healthcare professionals. Professor Dalip, for fear of, the pronunciation again, and he'll get me for this, for his sterling contribution to the understanding of the metabolic events in diabetes and use of these findings in informing patient care. He has been honored with invitation and accepted membership in several distinguished professional societies. These include the Association of General Practitioners of Jamaica, the Caribbean Diabetes Association, Caribbean Public Health Association, American Diabetes Association, New York Academy of Science, and the International Diabetes Federation. He is also a fellow of the Royal Society of Public Health. He served as technical advisor to PAHO and in guiding and supporting national quality improvement initiatives for diabetes care in the Caribbean. He provided consultancy services to the International Diabetes Federation, headquartered in Brussels, where he was appointed North American Regional Representative to the Diabetes Education Consultative Section, as well as the World Health Organization, at the World Health Organization, Geneva, Switzerland, on the Pairs in the Progress Project, and more recently, the WHO Guideline Development Group for the Global Nutrition Actions. Professor Ragoobirsingh has authored over 100 abstracts, referred papers, book chapters, and technical reports on diabetes and its complication, which have also been presented at international conferences. Although born in Trinidad, and I think he wanted me to note that, although born in Trinidad and Tobago and resident in Jamaica, he is an unrepentant regionalist and a Caribbean man at heart. And he also wants me to add, it's not on your program, that he's married to a Jamaican, and it seemed that many doctors, including the late Bernard Andrew Sorhaindo, was also married to a Jamaican. And seated next to you, Dalip, is Hazel Ricketts, who, the name Ricketts, hails from Jamaica. And we can call Professor Grell, ask him, hails from Jamaica. So there is oh my God, I've now realized Dr. Riviere is there, seated with his Jamaican wife. And although I don't want to jump the gun, my son, who is a doctor at the Kingston General Hospital, has had a long-standing Jamaican girlfriend. So I don't know what the affinity between Dominica and Jamaica, but somehow, I think it was said in Barbados a few years ago about Sandiford, and a calypso came out, all them politicians, no Bajan. That means all the politicians were married to people from outside Barbados, mainly Jamaicans. So there's something, Mrs. Sorhaindo, about Jamaican ladies. Okay, we'll find out as we invite to the podium our presenter for the night to speak on the 7th annual Bernard A. Sorhaindo Memorial Lecture, Obesity, a Caribbean Dilemma, Dr. Dalip Ragoobirsingh.
I want to say how grateful I am to the organizers of this lecture for taking the risk of inviting me to address you tonight on this topic of obesity, Caribbean dilemma. I also want to publicly acknowledge the hospitality and warmth that I've received, not only from the staff from the Open Campus, but from Dominicans that I've met here in the hotel and elsewhere that I've been over the last few days. You know, I'm humbled that I'm asked to speak, you know, or to give this lecture in honor of one of the Dominican's icons who have served, you know, the medical profession with distinction. And I believe that, you know, this gentleman, why I'm honored is because he, though had an illustrious career, you know, and walked with kings, still never lost his common touch. And I believe that it was because it was underpinned by a deep spiritual, you know, value. And I respectfully acknowledge it. And I want to add, I feel sure that he is having a strong Jamaican wife would have also contributed significantly to this. I believe he, like all of us who are married from other territories, are regionalists, and we are doing our own part to build CARICOM. And that's how I view it. All right, as already has been advertised, the title of our topic tonight is Obesity, a Caribbean Dilemma. Now, globally, 25% of the adult population is seen as being obese, overweight, obese. In fact, I spoke to Dr. Ricketts' male by phone, who unfortunately is in Trinidad, and he said he sent me some information to say that at the last survey in Dominica, 20% of the adult population was obese. In fact, like almost everywhere, women are, of course, in the ascendancy. And overweight here is like 45%. And adult here is taken as 15 years and over. There is not a lot of information on adolescents, but I was privileged to be collaborating with the Florida International University, who looked at adolescent students in 10 schools in Jamaica. And interestingly, 33% of that population were already overweight to obese, and they were showing evidence of the metabolic syndrome. And this is below 15 years of age. And I will not be surprised if the same thing will be seen in Dominica. I was speaking to my colleague, Dr. Shillingford Ricketts, who was saying to me that they are planning a massive study across the island, and I compliment her, and I want to encourage you to do so. But having done so, you know it is unethical if you do the study and don't do intervention. So I will support you and encourage you and hope that you proceed accordingly. How do you know? There are two diagnostic tools which are used. One is body mass index, and this is where you take your weight in kilogram, divide by a height squared in meter. And if you are less than or equal to 19 kilogram meters to the minus 2, then you're undernourished. And I don't think I've seen anybody while I've been driving through, or being driven through, I should say, I beg your pardon, in Dominica, who is really undernourished. If you are 19 to 24.9, then you're okay, you have good weight for height. 25 to 29.9, you're overweight, and over 30 is what we consider to be obese. You can also take a waist measurement. Now let me say, waist measurement is not like when you go to the dressmaker. The dressmaker puts the tape around you, and anywhere that is small between below the breast and the hip is called the waist. That is not clinically the waist. The waist clinically is the midpoint between the lower rib margin. You can feel it. Now if you can't feel it, don't bother to measure. All right? So it's the lower rib margin and the hip bone, or what is called the iliac crest. Usually when it comes across the middle, it coincides with the navel in most people, and parallel across the back. For females, it's 80 centimeters. It should be less than 80 centimeters, and if it is, that's roughly 32 inches. Then you're okay. For males, it's 94 or 38 inches. Now, when I was a student in 1930, we often used to say that the females who had smaller waists had the shape of a Coca-Cola bottle. But as you know, Coca-Cola come in square cans now, so you can't really use that. But these are the two diagnostic tools that you use to define obesity. We in the Caribbean are our worst enemies. We are in the Caribbean our worst enemies because we have some traditions and folklore that, you know, I think facilitate obesity. One of them is traditionally being overweight has been viewed as being healthy. Is that true in Dominica? Fat women are considered to be more attractive. The men here could speak for themselves. And also, it is a sign of prosperity. Interestingly, I was invited to give 3 seminars in London during July, and it was mainly to the Caribbean diaspora. And those who left our shores back in 1950s, etc., still retain these traditions, and some of them came with their children to the seminars, and the children could testify that in the home these are some of the things they heard. Our main problem is our diet. Our diet is both in terms of the quantity and the quality. As a people, our caloric intake is always invariably in excess of our bodily requirement. And the excess is always laid down as fat. There are other reasons for obesity, which I would not raise, except it is raised in the question and answer, but there are other reasons which you might say are legitimate reasons. For example, if you have a patient who had pelvic surgery and is non-ambulatory, it's likely that a patient over time may become obese. There are some endocrine problems, something like myxedema or hypothyroidism, where the metabolic rate is low. The patient tends over time to become obese. All right? So there are some, like in terms of where you have hypogonadism or low testosterone, you tend to attract or to have intra-abdominal fat being developed. So there are a number of reasons why people can become obese. But the main causative factor is the way we eat. Now, I want to use this to give just a kind of insight into what happens when we eat, and then to segue or to move into how obesity really is affected by what we eat. This here is really a picture of food in the blood once we have eaten, and the pancreas produces insulin. And both travels in the blood to the target tissues, which include the liver, adipose tissue, skeletal muscle. And as I often say to both my patients and my students, the insulin acts like a key, and it opens locks which are on the surface, the cell surface of the target tissues. And what happens once you open the lock, food flows freely from the blood into the cells. As you get progressively bigger, moving from normal weight to overweight to obesity, you notice what is happening. All the food remains in the blood. All right? And what happens is as you get obese, the insulin is not able to fit on what is called a receptor, or the key is not able to fit properly on the lock. And so it does not open the channels to allow food to flow from the circulation into the cell. This is not pornography, Pastor. This is obesity. All right? And this is why obesity is the major risk factor for diabetes. I wanted to give a simplified definition of diabetes as a persistently high blood sugar. When we eat normally, if you're a normal subject, within 2 hours, the blood sugar returns to normal or near normal. But if you are a diabetic and untreated, or you didn't take medication or treatment, then the blood sugar remains persistently high. There are 2 types, classical types. There are others, but these are the ones that are the classical types. Type 1, which is called insulin-dependent diabetes mellitus. Type 2, non-insulin-dependent diabetes mellitus. Some of the common classical symptoms include frequent urination. The body tries to pass out the excess sugar in the blood, and therefore it is excreted in the urine. So you tend to go to the bathroom, quite often. And because you are passing out a lot of water, you tend to drink a lot. So you have what is called polydipsia. I often tell my patients and students that diabetes is starvation in the midst of plenty, because you have a lot of food in the blood, but it's not available to the cell. So the organs are telling the brain that we are starving. So patients are constantly hungry. And patients who are diabetics tend to be predisposed to itching infections, which we'll talk a little bit about as we progress. But these are the classical symptoms. There are others, but these are the common manifestations. And for the clinicians, polyuria, polydipsia, polyphagia, and pruritus. Just to give you an idea of the profile, the patient profile of type 1, these, beg your pardon. These tend to, the insulin that are produced, if they are produced at all in these patients, are essentially ineffective. So they are dependent on exogenous insulin. They are prone to ketoacidosis. In fact, if you work in accident and emergency, and patient come in with that sweet smell or that scent of like nail polish remover, it is because the patient is fast going into a ketoacidotic coma. They are producing a lot of ketone bodies. They will complain of recent or precipitous weight loss. And this is because although you have, as I said, a lot of food in the blood, the body begins to break down the muscle in order to survive. And that's why patients on presentation tend to complain of precipitous weight loss. The onset of these usually at one time was seen mainly in juveniles, in children. As a matter of fact, this is the type that was called juvenile onset. But now that it is appearing increasingly in the elderly, the WHO has accepted a recommendation to change the nomenclature to type 1 or insulin-dependent diabetes mellitus. Is everybody okay? Are you understanding my accident? Yeah? Everybody's okay? And I'm not speaking too quickly? No. Yeah, okay, good. If I am, you can, wave your hand. Not a flag now, wave your hand. Type 2, these are not dependent on insulin. In fact, it is only in a very stressful situation, whether if there's a pregnancy, an infection, a trauma, you may have to introduce small doses of insulin to help in the management of these patients. These patients may present with a very high blood sugar and are free. They are what is called asymptomatic. They don't have the normal classical symptoms. They are not prone to ketoacidosis, although it has been reported. And it's this type of diabetes that has a strong family history. So if grandma has it and if Miss Mama is likely to take you. All right? So this has a strong genetic component, and it is usually in patients who have had a history of obesity or is presently obese or overweight. At one time, it was seen in age group over 40. So if you are fat and 40, then you are a prime candidate. But of course, as I said earlier, it is already beginning to show up in the adolescent age group. And again, WHO accepted recommendation to change nomenclature to type 2 or non-insulin dependent diabetes mellitus. These patients actually can be managed just on lifestyle, and I'll talk a little bit about that towards the end of the lecture. Just by good diet and exercise, and if they are not managing well, then you might introduce some tablets, some oral hypoglycemics. And as I said, in a stressful situation, you may need to give some insulin. 8 to 14 in every 100 adult, again, adult here is 15 years and over, across the Caribbean, is diabetic. All right? With an average at the last meeting in Dubai that I attended for the International Diabetes Federation, the president was saying that it is on an average about 11%, 9.3% women, and like 6%, when you disaggregate the figures, 6% men, so women in the ascendancy. 90% is type 2, so 9 out of every 10 diabetic will be of the type 2 variety. And the 2 to 4 of them are waiting to become what is called IGT, or impaired glucose tolerance. Now, if you are in that category, and the clinicians who are here, I want to suggest to you strongly that you manage these patients aggressively. I'll tell you why. Because these patients are predisposed to the small vessel and large vessel complications that you would have if you are frank diabetic. So I humbly would like to suggest to you that if those of you who are here, maybe you are IGT, your doctor said, well, look, you're not quite diabetic, but you're not too far from it, then you should be managed aggressively. And most likely it will be, a low-caloric diet, walking exercises, and keep, being monitored. But I wanted to make this point because very often these people will eventuate into full-blown diabetes and need not. The complication might begin to show up even before that, though. Diabetes can be controlled, not cured. Cardinal to it is the diet, which we'll talk about towards the end of the walking exercises. And of course, the other modalities will be tablets. There are a variety of oral hypoglycemics, and of course, insulin. I included this slide on the advice of my wife, who said to me that it's good for you to talk about, you know, all the different modalities, but if you don't talk about what affects us in the Caribbean, then your talk will be of no use to man or God. And with those instructions, I had to include these slides. These remedies are widely used. In the introduction, you heard I was the technical advisor in 10 territories, which unfortunately did not include Dominica. But in the 10 territories, we were doing this improvement of quality care of diabetes. And in all of them, bar none, including the group I saw in London recently, from the Caribbean, people of Caribbean origin, bush teas is widely used. I'm not sure if that happens in Dominica, but it is indeed, and it's causing a lot of grief. It's causing a lot of grief. There are indeed some components in some of the bushes which may show an improvement in blood sugar, either real or imagined. Sometimes it masks the sugar, or sometimes it may actually be lowering the blood sugar. I recall one professorial colleague was reporting to us at a meeting that she had this patient, elderly lady, who came in and said, "Doc, I have been healed." So she said, "What do you mean?" She said, "Well, when I checked my blood sugar last after taking my bush, I see no sugar appearing in the urine, and that in the blood seemed to be okay." 3 days later, they called the prof, because the patient was on the ward in a hypoglycemic, non-ketotic coma. What was happening is the bush was masking the blood sugar. So the blood sugar was really high, but the readings that she was getting wasn't accurate. Here are some questions which I want to posit to you, and you can think and reflect on them and see whether, you know, it gives you can come up with any answers. How much would you have to take if you were taking bush? A handful, 2 leaf, the root, the bark? Are there harmful substances? In some animal studies, I was telling Professor Grell, a senior colleague, esteemed colleague, that in our metabolic team, we had actually done some work on animal studies, because in dog models, which is the best model for diabetes studies. And we said, we fed, and we had a vascular surgeon come in and biopsy liver, kidney, and we passed it to one of our deceased senior professorial colleagues, an anatomical pathologist, who looked at it and he saw evidence of damage in the liver and the kidneys. So a word to the wise is sufficient. Clearly, there must be some active ingredients that may be lowering blood sugar, but there are others which, when you boil it, comes out also, and that is affecting some of the people, other organs. And you also want to know whether there are any cross reactions between the prescribed medication and the components of the bush. Kidney failure is a major cause of death in diabetes. I want to refer, I was telling Professor Grell earlier, that much of the studies that that has come out of the medical school in Jamaica in diabetes started with our late colleague, who was a contemporary of Professor Grell, my compatriot, Professor Richards. And it was back in the 70s that he saw patients presenting on the wards, and my senior colleague, Professor Morrison, was then, I think he might have been a registrar prof, working along with Professor Richards. And when I joined the team in the mid-80s, that was before you were born, we did a retrospective study. We matched patients who admitted that they were taking bush medicine, either replacing or taking along with. And we matched them in terms of gender, duration of diabetes, and as far as possible, age. And those who were on taking the bush were excreting more microalbumin, which is the diagnostic test for kidney function, than the other group. these patients, it appears to be more vulnerable to kidney failure. In fact, my compatriot, Professor Barton, is currently spending a lot of time setting up dialysis across Jamaica. I'm not sure whether you have that service here, but you would fast need it if patients continue to use this. It is against this background I come to Dominica tonight to issue this warning, respectfully, that where scientific support is not forthcoming to explain any benefit of the use of a medicinal plant extract, then it should be discouraged and cautioned against as a possible harmful practice. And do I hear an amen to that? All right, just to go through some of the common complications which we spoke about, the small vessel and large vessel complications. Diabetes is the leading cause of blindness. It is also responsible for diabetic nerve problems. And I want to speak respectfully about impotence. Very often, impotence is seen and is felt to affect only males. That is not true. The experienced clinician with proper questioning will detect that females also suffer from impotence. And it is manifested, and I say respectfully, usually there's a decrease in libido, there's dryness in the vaginal tract, and painful penetration, which, if continued, can lead to severe infections, which can be very unpleasant. And so I would suggest to you, if you are diabetics and you are having those kind of issues, that you discuss it with your clinician. And doctors who are here and healthcare professionals across the board, it would suit you to ask probingly the questions respectfully. There are simple suggestions you can make to both. I like to speak to both spouses whenever I'm discussing this particular issue. And there are some useful suggestions, simple ones, that you can get over the counter that can help female patients not to suffer from this or to help with this particular issue. I want to include a few slides on foot care, again, on the recommendation of my dear wife, because we in the Caribbean has now become the amputation capital of the world. We lose more lower limbs because of diabetes in the Caribbean than any other region in the world. And again, it has to do with a lot of practices that are peculiar to us as Caribbean people. First of all, wear your size. Wear your size. I don't know if it is true in Dominica, but in Jamaica and some other Caribbean countries, women between the age of 18 and 35 wear two shoe sizes smaller. Is that true? That's not true here. But that can be uncomfortable and can be the cause of much distress. But wearing your size, how do you do that? Here are some shoe tips. And I want to speak to these because they seem very simple, almost silly, but they can prevent a lot of woe and crises. The shoes should not be too tight or too slack. In fact, they should be comfortable. And for that to happen, they are best bought mid-morning. Our feet is smallest in the morning when we get up from sleep and largest at night when we retire. So if you buy shoes on the extremities of the day, you find that it will be uncomfortable at some point during the course of the day. Mid-morning, the shoes will not be too slack or too tight at any time during the day. And there isn't enough, it wouldn't be squeezing up the foot, and it would not be causing the foot to play and rub so that it gets bruised. Shoes should breathe. Air should circulate freely between the toes. So it means that you should buy good leather shoes. And my patients in Jamaica love to wear nylon socks, Pierre Cardin, things that I can't even pronounce, let alone afford. But my suggestion to you is to wear cotton because it mops up the sweat from between the feet and keep them dry. Foot care. Wash feet with water and soap and dry, especially between the toes. Sometimes I encourage my patients to have like a rag, especially for their feet, to give their feet good care. Examine the foot bottom with a mirror. If you can kick up your foot and look under it, then use a mirror. And I'll show you one slide later down if this patient was listening to that, then he would not have lost his foot. It soon comes, sorry, it will come shortly. Cut nails with clipper. I have patients who are farmers that use a machete, a cutlass to cut their nails. Some people use a penknife. Remember that the feet are furthest from the head, so sensation in the feet goes quickly. So even if you get a little nick, you don't recognize it. And by the time it begins to putrefy is when you recognize maybe by the scent. Don't soak your feet in hot water. That's a common practice in Jamaica. And they put Epsom salt sometimes, ruralites. In fact, I was invited by the Open Campus in Grenada. And a member of staff from Open Campus, a young person, he used to do marathon. And he admitted to me, he said, Prof, when I do my training and I come home around 7 o'clock, I used to put up a bath and put some Epsom salts. And I soak in my foot while I have my dinner and listening to the nightly news. So it is not far-fetched between young and old. But the thing is, if you are diabetic, you don't have that sense in your feet to know how hot it is. Sometimes it burns off the top skin. And before you know, gangrene set in. This is the patient. This patient here, walking barefooted. Now, had he been walking around after his shower, looking at his foot, either feeling or using a mirror, what happened to him? A thumbtack stuck in his foot and was there for at least a week. One day, he's smelling something and thought it was a rat. Little did he know that maggots had started on his foot. And I needn't tell you, the clinic physicians here would know that even if you amputate from the ankle, invariably, it goes up to the knee. Not true? Those who are surgeons, the surgeon knows that is true. There are some things that we do. You know, home remedies is a common thing in the Caribbean. All right? We like to play our own doctor. Do not cut corns and calluses. You see what you see what will happen if you are doing that. Don't use corn cures, paint, and plasters. Poultice, prick blisters, or use iodine. These can be the cause of great woe. Okay? So these look simple, as I said, almost silly, but you'll be surprised. You would be surprised how many feet could be saved by observing these simple practices. Now, we have discussed quite a bit about type 2 diabetes, and indeed, obesity is the risk factor for type 2 diabetes. But it also is the risk factor for increased blood pressure, hypertension. I think Prof. Grell might be better able to speak to that than I can. Coronary heart disease or heart attacks, myocardial infarctions, and strokes. And I will speak to these very briefly because I know the time is limited and I don't want to bore you and wear your patience. But I want to show you as best as possible how these present, and then it will be remiss of me for you to have brought me here and not give you some useful tips to help in either prevention, stroke management of obesity, and then we close for tonight, God willing. Yeah? Now, I'll explain this. One of the common metabolic problems in obese people is that they have high fats in the blood, or what is called hyperlipidemia. And usually when the blood fat reaches a certain critical level, it begins to bruise the vessels of higher blood pressure, which will include those that feed the head, those that feed the heart, and those that feed the kidney. All right, and that's what we call endothelial injury. And like all injuries, you find that gravitating towards the injury will be a number of cells, white blood cells, you'll have some platelets, you'll have other things, which gives rise to foam cells. And that is how you have essentially the hardening of the arteries, which I'm sure you have heard of. All right, hardening of the arteries. This is a video. Watch it carefully, and you'll see the process that is occurring. It's highlighting the artery feeding the head, the carotid artery. And you'll notice that how the lipids are depositing on the inner lining, the intima of the blood vessels. Pieces are breaking off. You have platelets, blood clots, cholesterol, right? And you have a mixture, and it goes up into the head, into the brain. See, this is the internal artery. This is the vessel it is happening in. It goes up into the brain, and there you have it, what is called a non-bleeding, a non-hemorrhagic stroke. That's one of two types. All right? So you see, obesity is not just, You know, there's something now these days in Jamaica they call the fluffy diva. They're parading themselves that this is, you know, but nothing goes so. Sorry, nothing goes like that. All right, see, the same thing is happening in the heart. All right, and as the vessel, this opening gets smaller, it is reducing the food and the fuel that is going to the heart as an organ. And after a while, the contractile fibers in the heart begins to become stiffened. And what happens? The heart is beating, and one day, just so it stays so, and you bam, MI. All right? Just like that. Just so. All right? So we have non-bleeding strokes. We have also heart attacks as a result of hardening of the arteries. Now, we also have, if the same process occurs in the kidneys respond in two ways. It increases blood volume, and it also causes generalized vasoconstriction, or the constricting of the blood vessels, both of which will result in high blood pressure. Now, high blood pressure can also cause heart attacks. What happens is like when you go to the gym, when you lifting weights, what happens to the muscle? They begin to enlarge. So if you have a persistently high blood pressure, Prof, tell me if I'm going right or wrong. It is like if the heart is bench pressing a certain weight, and after a while it begins to swell. And although you have new vessels being created, what they call neovascularization, that cannot go on indefinitely. So after a while, the heart, the contractile muscles begin to become fibrous. And it's another mechanism by which you have a heart attack. So you see, it's really a vicious cycle. And same thing, you can have what is called a bleeding stroke, because the high blood pressure ruptures a blood vessel in the head, and you have what is called a hemorrhagic stroke. So you have different types of strokes by different origins, and different types of heart attacks that is from different origin. All right, so obesity is not as simple as that. It is much more than it appears. Just the overweight, people feel, well, boy, I'm just, I'm overweight, so I'll get an oversized dress or pants, and I'm cool. Nothing is like that. All right, I think, as I said, it will be remiss of me if I don't give you some pointers, and chief of which is nutrition. I will give you some what I'll call the tenets or the principles of nutrition therapy. But this you have to work through with a qualified nutritionist or healthcare professional that will sit you down and prescribe something that is suitable for you at your age, for your gender, your weight, if you're on medication, etc. Okay, but I'll just give you some general things that you would want to refer to. Always try to maintain a near normal blood glucose. People think starving is dieting. All right, so sometimes people walk around hypoglycemic. They feel they're drifting, but thinking that they're doing themselves, some good. All right, so make sure that the diet that you're taking is nutritionally adequate. That your lipids are at optimal level. It's not too much and not too little. I have qualms about it, and if you ask me, I'll tell you why. All right, you want to try to maintain or to attain a reasonable weight. You want to facilitate normal growth, especially in the children, as we know that they now are fast catching up in terms of overweight and obesity. And of course, since our women are, more vulnerable and seem to be, more obese, you want to also facilitate healthy pregnancies. All right, some more specific information. All right, always try to get about 50% of your calories from staples. And I want to say that try to consume staples, and the staples in the Caribbean are the best staples because they are high in fiber, and as such they are absorbed slower. So your dasheen, your cocoa, your banana, your plantain, your breadfruit, your yam, these are far better than some of the other staples, which could also still be useful. Beans and beans is very common in the Caribbean. These are also a good source of carbohydrate. But importantly, they are high in fiber and low in fat. Now, balancing it is where you will need the assistance from a nutritionist. I want to make this point, however, just in case you start on your own, and also to the healthcare professionals. I show this because the brain, the central nervous system, almost exclusively use carbohydrates as a source of energy. And this is the minimum amount for it to have proper brain function and nerve function. So when you are putting your diet together, if you decide to restrict carbohydrates, 1 serving of bread or starch, 1 serving of fruit, or 1 from the milk group will give you at least this, which is the minimum to ensure that your central nervous system is functioning. So bear that in mind, those of you who intend to follow this prescription. Vegetables contribute little carbohydrates, and they are not counted, but they are very important. They are an important source of minerals and vitamins that is of paramount importance in the proper functioning of your muscle and nerves, and you should try to have a healthy portion at least daily. They're high in fiber, low in fat. I usually tell my patients the green leafy ones you could eat until you turn green. The yellow and red, half cup to a cup, will be useful because they might have, especially if they are diabetics, they might have, some amount of fruit sugars. Meat, good source of protein and iron, but could also be high in fat. So my suggestion to you is to use low-fat cuts of meat, and you can include low-fat milk and cheese. I want to add also that when you are seasoning your meat, especially people of color are at greater risk for hypertension. And so this seasoning salt that we love that looks nice when you're throwing in, is living dangerously, as one of our DJs in Jamaica say. You're living dangerously, you know it? All right, that's you're living dangerously. Do like my Rasta brethren, use natural seasoning, onion, garlic, thyme, scallion. You're going clear. And try also to use preparations that you don't have to use a lot of oil, etc. So you want to bake, grill, steam, and leave the other preparations, as I tell my patient, for an occasion. The festival coming, you might want to eat some fried fish or fried chicken. But on a routine, you want to stick with the more healthier preparations. And a word to the wise is sufficient. Fats and oils, we should try to use minimum of these, all right? Try to move from using animal fat to vegetable source of fat, but generally try to reduce the amount of cholesterol because we already see what are the problems with respect to that. So time your meal appropriately. If you're on medication, you'll need to talk to a healthcare professional, and if you're diabetic, you would of course need to know the peaks of, when insulin is peaking, etc., especially if you're an insulin-dependent patient. I was just in Geneva, just in July, as part of an expert group, and we are discussing how we can regulate the intake of salt, table salt, globally. No more than 6 grams or 1 teaspoon is what is recommended per day. In the Caribbean, I think we consume 2 to 3 times that, and you want to take note of that. All right, I've already said to you that you must less fried and high-fat foods. I have patients who tell me, Doc, if you tell me don't eat fried dumpling, you're like, better you take my life from me. And so I tell them, I say, look, to avoid withdrawal symptoms, if you eat it 3 times, start going to 2 and work your way down. Your taste buds, can be trained. But I'm very serious. Our fried foods, fast food, take gravy and sauces. Unless we see ackee swimming in oil, we're not happy. All right, and covering breadfruit and oil running down the side of the plate. We have to move away from that. That is what is killing us, and killing us slowly. Moderate exercises will help. Your Excellency, I have to admit to you that whenever I feel to exercise, I just lie down until the feelings go away. But I want to suggest to you that moderate exercise will help. And I say moderate because as you get older, as you get to 40, the surgeons here would know, especially the orthopedists, the small bones in the feet begins to change. Yeah, what is called osteoporotic changes. And if you are diabetic, I'm told, these changes take place 5 to 7 times. That is why if they land heavily, they can fracture the bones in the small feet. So I usually advise patients to do low impact exercise, moderate, walking, swimming, cycling. And usually benefits of exercise: reduce body weight, reduce blood sugar, blood pressure also goes down, blood cholesterol, and if you're on medication, usually you have a reduction in your prescription. The regimen usually changes, and of course there's some savings in the pocket. For Dominicans who are rich, not like us poor Jamaicans, well, poor Trinidad and stroke Jamaicans, that makes a lot of difference to us and to our patients. Other additional lifestyle: reduce alcohol consumption. And if you smoke cigarette or anything else, I will suggest that you stop. All right? So cessation of cigarette smoking and anything else that you might be smoking, I would suggest that you stop. So in conclusion, colleagues, friends, Your Excellency, if you are to treat effectively stroke, prevent obesity, you want to control the amount of fat you're taking in, how it is the amount that is deposited, and how it affects body weight, etc. Lifestyle, which we have discussed in detail, is cardinal to this. If lifestyle is not as effective as you would like, with your clinician, your physician, there are drugs that can be used to supplement lifestyle changes. And in the case of morbid obesity, you may want to refer to the surgeons to have maybe gastric bypass or liposuction. I do feel, and I hope you agree, that he who does well will feel well. And with that, I want to thank you for your time and your attention. The Prof love you here in Dominica. I'll be happy to answer a few easy questions.
I get the impression that we are going backwards. And that is why your talk here is very timely, and Felix, that's the best thing that you could ever have done to Dominica at this time. Now, let us go first of all into the causes, because this obesity has just descended on us in Dominica, and I don't know what we're going to do. And of course, we have to practice what we preach. That is why I always believe in myself keeping my weight down. No matter how busy I am, I find time to exercise. You have to look after yourself. But on the other hand, things have changed. When I was a child, there was only one bus where I was living. Now we have how many different transport? People are not exercising at all. There is this technological age that's just caught up with us, and we are not planning for it. We can use technology, but we mustn't make it overtake us. And it has overtaken us right now. Now, the other cause is, again, in schools, the exercise, they don't have this exercise anymore. Children have all their whatever in their ears and so on. And parents now, especially those that don't earn a big income, they have it very, very tough. So you get children money to buy bakes. You know, I myself as a mother always did cook my food. No matter how busy I am, I cook my food. Now, how many mothers at home now cooking food? Mothers have to go to work. So therefore, they give their children this money. So we have to plan for that. That means out there that they're selling things by the school, they must do things that are practical and that are not happening. Because that's what's happening. How can a mother have to go to work and still look after children? It's not done. And then the men now must come and play their part. Men have to come forward now, because men, my mother had 16 of us, 7 of them were boys, and they never went by the stove. You see? But now they have to come by the stove. And that cause.
Yep, they only come by the stove to collect food.
Come by, exactly. Another thing is the breastfeeding. People always look at, and even Dr. Sorhaindo, all my children under Dr. Sorhaindo. And I felt I had to come and go to Obesity and Dr. Sorhaindo himself. We used to have a good, every time I come pregnant, again you came back again. And then now I always breastfed my children. My last child breastfed for 3 years. And I went on conference just like this. 6 months old, I said, I can't leave for with my husband. He hasn't got breast to breastfeed. So I brought her there. Today she's in Canada, she's been a doctorate, so it is her good with 3 years of breastfeeding. You understand? And people are now making excuses. They will come to the clinic, child by a year, they start giving them bottles with cereal, thick cereal, and then they just get big. And that is what is happening now. We have not stood up and said, well, look, this is what's going on. Let's see how we can plan.
Yeah.
So we must, in the Caribbean now, begin to plan, or else we finished. More or less now, it's nice clothes, we go to a party, then we have all these rapid fest, alcohol drinking, more calories again, and that is what it is. So it's a very serious matter. Now for the fact that the causes, some of the causes I haven't mentioned, but I want to go quickly because I want to give other people a chance to talk. But when you go to the next part of the diabetics that I see, I mean, I'm glad you brought on the point that obesity is one step towards diabetes. Because people think I'm talking nonsense. You know, they put on weight, I say, but you should try to lose a little weight. Oh, well, it doesn't matter, my man likes me like that, and so. Well, let the man get fat himself. So what is happening is that, people are just, they don't connect the whole obesity and the pancreas under stress, giving, and over time, that's what happened. Up to last night, I met a man. He has a higher blood sugar, he takes it. And now we have in Dominica a number of global places, a number of so-called wellness things, I don't care what next time, okay? That are just telling you have a clot, that's true, okay, take a herb. And they don't go to the doctor. Go to the doctor, if it's a clot you have, the doctor will diagnose and they will give you something. They come to me and say, you joking with your life. You understand? And that obesity is leading to, that is a direct path towards diabetes. And I was in Australia for the last World Diabetes Conference and I got back. And I'm sorry that the Minister of Health is not there. He should be there because he was in Australia himself. You understand? And I'm glad you say policy. Because from Dr. Grant's time and our time now, the whole emphasis on the primary health care has gone down. Patients should be having special diabetic clinics. What is happening now? Everybody comes to a clinic, they hurry up, doctor, take their pressure, I want to back my home. No, it's not like that. I actually have a diabetic clinic at Ross University where I work, and we go to the hospital, I give them a quiz, we start off. Some people believe baking an ECG to stroke. Yes, there are lots of things. I just spoke about the food. I have a question in the quiz. Which of these foods have starch? And they will have things like meat. They don't know the difference. A lot of people don't know the difference. Not necessarily everybody, but there's some people that need to be taught about food. And they do not know. So they just eat. It's just manger. You understand?
Yeah.
So this diabetic case, we have to structure them, go back to the, and we have to get more nutrition. Look at Jacqueline there. We work very hard on that. Right now, Jacqueline is retired. I myself am at Ross. And I just wonder what is going on in the clinics, because nurses have more time, and patients just come, they take their blood pressure, and they don't realize, some of them don't even know what is HbA1c. Blood diabetes for how many years, you don't know what is HbA1c. And you're supposed to know that. So we're not educating them enough. So education is one big strategy, and we need the wherewithal to do that education. We are not doing it, and we are going back. I saw Mr. Blanchan is there. You can hear me, I will, because Marvin is now not well. So we have the association, they really need help. And we need to give them support. And this lecture, there has to be played with every single clinic, because it is simple, and it's to the point, and we must take things in hand in Dominica as we figure out.
I want to encourage, I think patient education must be such that patients must be so empowered that if they go to their regular doctor and he or she did not look into their eyes, that the patient can say, well, you know, doc, the last time I was here, you didn't look into my eyes. Can you do it on this occasion? And I think that will help considerably. We have to learn, our patients have to be empowered. And I want to strongly suggest, with respect, that the health team, and I use the term team deliberately, that it must be a team effort. Gone are the days when practice of medicine is doctor-centered, where the doctor was, you know, king nobody, lord over nothing. You know, he had or she was the repository of all wisdom. It must be patient-centered. And we must also speak respectfully of our other colleagues on that team and encourage the patient to respect the other colleagues. I want to make one point, Dr. Shillingford, in response to the presence of nutritionists. If you can't afford nutritionists across the island, nutrition technicians or somebody with a nutrition background in the interim will suffice. Because, you know, we in the Caribbean, you know, getting, you know, an avalanche, a cadre of trained specialists, nutritionists, dietitians, food specialists, to spread across the country. It's not always financially viable. Governments have many things to do there and just split up a small part. So can I humbly suggest, because in Dominica, what we have done, for example, with foot care, we have trained a number of foot technicians who can do the basic things. And when it becomes a little more difficult, we can refer to maybe the chiropodist or then to the surgeon, as the case may be, which is the last place you really don't want to go. If you understand what I'm saying to you. So in the interim, you know, I don't want us to aspire to things that, try and do small things that are achievable and that will make a significant difference in the short term than trying to be too ambitious, where we radically want to transform the health sector. I could speak to many other things that you raised, because I could give you another lecture on lipids, which you spoke to, but I will leave it there. I want to suggest to the physicians here, though, to decide at which point you are going to introduce lipid-lowering drugs. Because I was invited to some of the other territories, and there was a major discussion. And sometimes you introduce it too early, and patients end up with hypolipidemia. Now, let me tell everybody, fats are not all bad, because you need fats for your vitamin D, which is responsible for the integrity and quality of your skeleton. Your bile salts, all your sex hormones are made from cholesterol. All right, so you do not want to, you know, to downplay the importance. Let me add before I take this other colleague. 75% of the cholesterol, this is what I tell the students, the doctors as well as my patients. 75% of the cholesterol that we use in the body is produced in the liver. 25% comes from diet. Now, if you become diabetic, or as you get bigger, the liver begins to pour out, and that's why I have a hyperlipidemia. And there are sufficiently reliable clinical investigations and trials which have shown that just moderate changes in dietary intake can improve vascular health considerably. And so I would suggest humbly to the clinicians here that you try lifestyle, and if you could get it done, if you can't get it done in 6 months, then you introduce. And I say that against the background. I was the consultant to Merck Sharp and Dohme when they brought Mevacor to Jamaica. And in a sense, I was supposed to be promoting it, but it would have been ungodly if I didn't put the riders in. All right, so clinicians, please note that you want to determine, and for your own population, you may have to decide whether it's 8 millimoles total cholesterol. You may also want to look at the profile to see whether it might be high total, but you may have high HDL, which is the one that gives you cardiovascular protection. All right, so you want to look not only just at the total, but you want to look at the profile. HDL, LDL, your triglycerides. And you can make a sound clinical judgment based on it. Diabetics should have blood studies done at least once a year. Eyes should be looked at least once a year. And by an ophthalmologist, not only by a GP. And this is with respect. Because the trained ophthalmologist will pick up if there is bleeding at the back of the eye, diabetic retinopathy, or whether there's new vessels are being formed and the sight is being. Sometimes you have floaters in the eye depending on the management of the patient. So there's a lot that can happen, but that will be for another time, God willing. Yes.
I have a quick question and a short comment. With regards, Dr. Sam Briskin, I'm trained as a surgeon. And you mentioned about Epsom salts and iodine important, so I'd like you to answer that. But also, as far as the comment is concerned, in the United States, was featured on the Discovery Channel for supervising a 1,000-pound weight loss, and wrote a book about it, making it applicable, emphasizing the nutrition, and moving away from the gastric surgery, which I was doing. But basically, as you mentioned, the culture in the Caribbean is very, very pro big size and weight. And in a lot of ways, we just ain't ready yet to get that weight down to a normal level. So I just want to emphasize to all our colleagues and to our listeners, you know, as far as weight is concerned, it is a primary thing as far as the non-communicable diseases are concerned. I have a copy of my book for you just as a reference.
Thank you. And, all professors can't afford to buy it.
So about iodine and Epsom salts.
Now, with Epsom salts, I said that usually they put hot water and they put the Epsom salts, which changes the colligative properties. In other words, the water is sometimes much hotter than it feels. And why I don't recommend the soaking of the feet is because very often it burns off the top of the feet. And as you know, it can become gangrenous, and eventually, by the time they get to a healthcare facility, it's time to take the leg off. Iodine blisters the foot. It blisters the foot. So if you have an ulcer and you put it blisters it. And as you know, with diabetics, the ulcers become progressively worse. So it would suit them. Rather than they try, the take-home messages, go to a healthcare professional and let him or her have a look at it. And they now will be able to do procedures which will preserve the limb and also prolong the life of the patient.
There is a new view that seems to be coming into your profession there, that the main culprit in metabolic disease is indeed nutrition, but in point of fact it has to do with the consumption of sugar, sucrose and fructose in particular. And I noticed you didn't make any mention of that there. I was just asking the question as to what you think of that view which is put forward by guys like Robert Lustig at the University of California and other persons like that, that sugar consumption, the overconsumption of sugar is the major cause of these diseases.
Of what?
Of these metabolic diseases.
Yeah.
Bearing in mind that the WHO just put out a recommendation that the world should cut its sugar consumption by 50%. The United Kingdom, I think, just made a recommendation that the amount of added sugar a man should take should be about the equivalent of half of what is in a can of Coke.
Okay.
So I know your views on that.
Let me respond to your question. And a lot of the reasons for the adolescent obesity that we are seeing is as a result of these sugar-sweetened drinks that they consume and energy-dense snacks that they are taking. And that is essentially contributing to the increase in obesity. In terms of the relationship, the sugar is a carbohydrate. And once you eat in excess, in fact, let me say this. If you eat even proteins in excess by way of interconversion of metabolites, the excess is laid down as fat. So this thing about people saying they're not eating any carbohydrates or not eating fat but eating more proteins is nonsense. Respectfully, it's nonsense. Because metabolites consumed in excess of body requirement usually, eventually, by interconversion of metabolites, end up to be adipose tissue or triglycerides. And that also will contribute to overweight. Yeah? I hope that answers, if not all, at least part of your concern.
My question is, since your assignment to PAHO and WHO, how has the Caribbean people, and especially the policy makers, responded to your recommendations, and what are your success stories in that regard?
Okay, thank you for that question, and that's a good way for us to think of concluding. I know we have 2 other people coming. All right, what has happened since, let me say, some has been done and there remains a lot to be done still. In a number of countries, and I believe it may be true also in Dominica, in a number of countries, windows have been opened where you can get the medication for the chronic diseases at little or no cost. In some territories, they have also included the blood investigations, A1C and lipid profiles at little or no cost. There have been partnerships between the Ministry of Agriculture, Ministry of Health, and the public in showing people who have very limited yard space how they can grow successfully vegetables in tiles. Quite interesting. So that it would help. Private sector has bought into it. Let me say this, government can't do everything. It must take a private sector, public sector partnership. Some private sector, some supermarkets in some territories have asked for a list of food items that they can stock. And on some days, they give it at discounted prices to people who will carry their health cards. All right, so those are just some. There has been in a number of the clinics, they have the use of DVDs, videos, playing with education such as this, so that patients who are sitting and waiting to see the healthcare professional can view it. There is an increase also in the number of simpler posters that is also being publicized in the clinics. Schools in Jamaica, for example, we have been able to successfully get the government to look at the quality and quantity of the food served in the school feeding program. And we are hoping to encourage them to extend the physical education as part of the school curriculum beyond grade 9 or Form 3 to some of the higher forms, because a lot of with what we have seen in the survey, you know that adolescent obesity is on its way, or is already here, and that would be one way to help. All right, so those are some of the ways in which we have seen, you know, small steps. I recall I was in one territory in South America, actually. In 2006, PAHO asked me to make a site visit and an evaluation of their clinics and some of their practices. And while I was there, I suggested to them, they were saying to me that in the city, it's difficult for them to have, you know, walking spaces and what. I say, look, don't depend on the government to do anything. Get one of your private sectors to invest in it. I went back to that country 2010, 2011. Their big telephone supply company came in and blocked off a whole area, green space, marked out walking spaces, and encouraged other companies to put up signs so that they pay for sponsorship. And they have even put in bathrooms. So people during their lunch hour go there, do their work, take a shower, pick up their lunch and go back to the office. That's what I mean by trying to do small things and get in partnership between the government. If you depend on the government for everything, nothing will go on. Sorry, nothing will happen. Nothing, and it's impossible. It's unfair, actually. You know, I hear them run down my Prime Minister of Jamaica. Sometimes they don't have water. I ask them, you want the Prime Minister to leave Kingston and go to St. Elizabeth to solve a water problem? You think she has nothing else to do? She has other people can do that. But we in the Caribbean have a habit. We run down especially if we didn't support that particular government. We run them down and blame them for everything. But we get nowhere. We'll get nowhere. If we make practical suggestions and we mobilize resources right within the country, and you can also invite, I've seen in some other territories, I don't want to call it territories, but where they use some of the foreign embassies, mediating perhaps through His Excellency. Some of the, you may find a challenge to put up a particular facility, but they might be gladly do it for you as a contribution, a civil service, a civic service to the people of Dominica. So there are many ways I can go on, small ways in which we have seen changes. And like I said, you know, there remains a lot to be done, but it doesn't mean that nothing has happened. You know, and I feel I'm heartened. You know, when I had my final exams, it was a Jamaican who examined me, who worked at the Mayo Clinic. And he flew me up to the clinic, the Mayo, to see if I wanted to work there. And I remember Professor Morrison, my senior colleague, said to me, "You're making a joke, man. Him can't come and take my man and just disappear with himself." And he said, I ain't gonna call. I ain't waiting for him to call me. I will call him. And I don't regret staying in the Caribbean. And my passion is to see, I could retire in another few years, God being my helper. Because I feel that we are on our way. I'll say this lastly. The 10 territories that we looked at included Belize, Suriname, Guyana, Jamaica, of course, St. Lucia, Antigua, Anguilla, Barbados, Tobago of Trinidad and Tobago, and Grenada. At the end of the project, which ran over from 2008 to 2012, I was asked to give a lecture on cardiovascular risk factors to the group of healthcare providers who participated. And I went over to the regional advisor for diabetes region and said, please, if you get another tranche of money, please include Dominica, St. Vincent and Grenadines, St. Kitts, Nevis, Montserrat, and I'll be happy. And I do this free of cost. They pay my travel expenses. They don't pay me to do it, but I do it gladly. There are more things in life than just money. I tell them. So with that, I will ask you to give others a chance. But you know, I hope that has answered your question to the extent that I could. Yeah. After Professor Grell, with your permission, I will end. I told you I'm not a young man. I can't go for long.
Professor, I am not going to try to call your name.
No, that's fine.
And I'm trying to give you an easy question.
Please do.
It is in relation to the identification of the symptoms of diabetes. And you spoke to the question of frequent urination. Mm-hmm. I would like you to tell me what you consider frequent between 8 o'clock in the morning and 6 o'clock. Okay. So that some of us may be able to decide whether we are diabetic or not.
I would have to look at your medical history. You want to help answer? Please do. Thank you very much.
My name is Desmond Blanchard. I'm a diabetic. I don't deserve this thing. I did not inherit it from my parents. I've always had a healthy lifestyle. I've always been active. Every mango season, I suffer a great deal.
I feel with you. I know it is. I know how it is.
There have been advances in cancer research, even the dreaded HIV. Now, you're a bright fellow. Whether or not you're going to be a part of it, is there any hope of a cure for diabetes in my lifetime?
Only God knows. But let me say this to you, seriously though. If I tell my patients that they can have a small mango, they will sit down and eat a half a dozen. And Jamaicans love, you can tell me if I'm wrong, love mangoes. You know, one of the things, this is the point I was trying to make when our other colleague spoke about looking after patients and not making them feel, you know, that they are a burden. You can have mango, but it's how much you're going to have, how often. I'll give you an example. Around the Easter time, it's a very common practice to have Easter bun in Jamaica. I don't know if you have that here. And very often, I don't think any doctor that I've trained will tell their patient they can't eat a piece of yeast. I'd be very surprised. I will disown them here and now. What I tell them to do is that you know you're taking your medication, you're following your prescribed diet. 2 hours to 2.5 hours after, your blood sugar should have come down sufficiently so you can eat what is called a tups, a small piece of butter. So it's not that you can't have it, but it's how much you're going to have. And the same thing happens for Christmas. Patients who come to me, some of them, like Professor Dalip, is high up in society. They will go to a cocktail party. And I will say to them, they say, Doc, I can't eat a piece of Christmas cake and drink some syrup. I say, sure, why not? When you go, you have your meal. You don't have to explain to anybody why you're not having a dessert immediately after. You time it. An hour and a half after, your blood sugar would have begun to come down if you are taking your medication. And you can have a small piece of cake and a little glass of syrup. And you're gone clear. So it is not that you can't have mangoes. And anybody who is doing nutrition, you could tell me differently. You can, but you can use it as a snack, 2 to 2.5 hours after your meal. The medication most likely would have been taken just before, just after, and you should be clear. But you can't eat a half a dozen of mango. That's a different thing. If you want a diabetic, you're just greedy. I have one comment in return. If I have to retire here, I'll have to get my wife's permission. And with that, I want to thank you all for your time and attention. Good night, everybody.